this meeting. So good evening, welcome everyone again. I'm happy to welcome you on the very first webinar of ERN-LUNG, which is publicly available for a great audience. The topic will be quality indicators for pH. We are going to record this meeting in order to share publicly and make available for educational purposes. However, our main objective is to start discussion on this very important topic and to foster further work within our rare respiratory diseases to elaborate such kind of structure. Paper which we are going to cover was published in the European Journal of Heart Failure, and I think I can speak on behalf of the other co-authors that we were really excited when we were contacted by the European Society of Cardiology to work on this paper on quality indicators in line with or associated with the pH guidelines. I would not like to spend more time on housekeeping, but you can raise your questions in the chat. We are going to answer after the presentation. We have dedicated time for this. But before I hand over the floor to our esteemed speakers, let us run a small poll because we would like to learn which disease areas you are representing. Lisa, can you please put on the poll, please? As you can see, you can also tick not only one, but more, so it's a multiple choice available. We will leave a couple of seconds and we'll move forward. Okay, so our very first speaker will be Suleiman. He's a cardiologist from UK, and he was, I think, I can say, one of the key drivers of this very interesting paper. As I mentioned, the ESC has a wide knowledge on quality indicators. They publish lots of papers regarding quality indicators, for instance, or heart failure or cardiovascular disease prevention. So, Suleiman, the floor is yours.
Many thanks for the invitation to speak, and many thanks for the nice introduction. My name is Suleiman Akhtar. I'm one of the interventional cardiology registrars at Leeds Teaching Hospital, and I'm a clinical research fellow at the University of Leeds. Again, it was a pleasure to work with a group of experts and experienced patient representatives on this endeavor to develop quality indicators for rare condition, which is pulmonary arterial hypertension. My talk today is going to cover the methodology of quality indicator development and how we designed this methodology and how we applied it in a variety of different areas, including the topic of today, which is pulmonary hypertension. So to start with, it's worth defining quality indicators, and quality indicators are tools that help clinicians, patients, regulators measure the quality of care. It's always important to measure the quality of any service provided, and quality of healthcare is a service that is provided by providers to patients, and it's very important to measure, quantify and assess continuously the quality of healthcare provided. Quality indicators tend to be categorized into structural quality indicators, which are measures of quality at the institutional or organizational levels. An example of structural quality indicators could be the availability of a certain service, whether a hospital have a CT scan or an echocardiography or an X-ray machine. So any equipment or facility or service availability can be measured using a structural quality indicator. Process quality indicators are by far the most widely used quality indicators, and they tend to measure the quality of healthcare at the individual level, at the individual patient level. An example could be prescribing of a certain medication or the consideration of a certain intervention when there is an indication. Outcomes quality indicators are also very important, and those capture not only hard outcomes like morbidity, mortality, hospitalization, but also patient-reported outcome measures like health status or health-related quality of life. And there are key differences between quality indicators and guidelines. Most people are familiar with clinical practice guidelines, which most professional societies tend to publish and update on regular basis. Guidelines, by their definition, tend to be comprehensive. They tend to cover the entirety of any condition. However, quality indicators are allowed to be specific, are allowed to be targeted for subcategories or subdiseases or subgroup of people for whom there is evidence of prognostic or beneficial therapies, there is gap in care delivery, there are actions that can be taken from measuring such aspects of care. So quality indicators are allowed to be specific, unlike clinical practice guidelines, which has by definition to be comprehensive. Clinical practice guidelines tend to address future care, tend to provide perspective recommendation as to what future care should look like. However, quality indicators tend to be applied retrospectively using electronic healthcare records or registry data in order to assess retrospectively the quality of healthcare delivered. Clinical practice guidelines tend to be flexible, allowing room for clinical judgment. Quality indicators, however, tend to be very precise with a very clear numerator and denominator to allow the actual measurement of the quality of healthcare. Why quality indicators are important? Because we know there are a number of missed opportunities when we translate science into care delivery that we provide on a daily basis to our patients. And clinical practice guidelines tend to address the first gap, which is how we translate basic science, research, experiments into clinical recommendations that can be interpreted by healthcare providers, whilst quality indicators tend to address the other gaps, which is how we can apply, how we can implement, how we can improve the adherence to clinical practice guidelines, but also how we can capture patients' experience, patients' perspective of the care they received, and also their quality of life based on the therapy that they received for their condition. And when we look at registry data, year and year, time and time, we keep seeing the same pattern, which is lack of adherence or missed opportunities or gaps in care when it comes to clinical practice. And this paper that we did using data from the Sweetheart Registry, we found that even in conditions that are very common, like heart failure, there are a lot of missed opportunities. There is a huge room for improvement, even for a condition that is very widely known, very commonly addressed, like heart failure. You will always see the same pattern, which are missed opportunities or areas for improvement when it comes to adherence to clinical practice guidelines, or in this paper, to heart failure quality indicators. And when we talk about a rare disease like pulmonary hypertension, the gaps in care and the variation in care between centers or between countries tend to be even bigger. And that led major journals like Nature to call for implementation science, or to call for more implementation science, which is not only emphasizing the importance of the development of guideline recommendation, but also develop methods that help implement those clinical practice guidelines recommendation into practice. And that led the European Society of Cardiology to develop a standardized methodology or standardized approach to develop quality indicators for the measurement or the quantification of cardiovascular healthcare, which was published a couple of years ago in the European Heart Journal, Quality of Care and Clinical Outcomes. And briefly, this methodology involved 4 key steps, and those 4 key steps were used to develop quality indicators for pulmonary hypertension. The first step involves identification, or the identification of key domains in healthcare for that particular condition or intervention, and then conducting a broad systematic review of the literature in order to identify those areas in which the gap in care is huge, but the evidence available is strong. because those are the areas in which quality indicators tend to be very helpful, because there is strong evidence to support the development of quality indicators, and there is lack of adherence to those life-saving or prognostic or beneficial therapies, so that quality indicators can really address these gaps in care. Following the conduction of the systematic review, a group of experts, a group of people from different domain expertise involving patients and patient representatives can develop a key set of indicators or quality indicators that can be used then to measure the quality of care delivered using data available, ideally routinely collected data like electronic healthcare records or clinical registries. And by doing so, the feasibility of these quality indicators can be assessed. This methodology has been applied in a number of areas. There are now published quality indicators from the European Society of Cardiology for a number of conditions, including acute myocardial infarction, heart failure, atrial fibrillation, cardiac pacing, cardiovascular prevention, as well as other domains like ventricular arrhythmia and people undergoing non-cardiac surgery. And those quality indicators have been applied in practice. In the UK, they've been used to measure the quality of acute myocardial infarction or heart attack care during compared with before the COVID-19 pandemic, and have been shown to be associated with mortality. So the adherence to those acute myocardial infarction quality indicators tend to be associated with improvement in long-term mortality. And even in heart failure, this is data from the Swedish database showing that adherence to the heart failure quality indicators tend to be associated with long-term outcomes. So again, as I've alluded to earlier, it was a privilege to be part of this group to develop the first ever set of quality indicators for pulmonary arterial hypertension. There's no previous published set of quality indicators for pulmonary arterial hypertension. It's a rare disease, but it is a disease that in which there is a huge variation in practice and a huge gap in care. There are evidence-based therapies that can help improve the quality of life and the prognosis of this condition. However, without identifying a standardized approach by which the quality of care can be assessed, it's difficult to identify and address these variations and these gaps in care. And I'm not going to go through the methodology again, but the development of these quality indicators was similar to all other ESC quality indicators, using the same standardized methodology which has been tested in the past. And these are the quality indicators which were developed in collaboration with the European Respiratory Society and the Heart Failure Association of the European Society of Cardiology. And again, I can't emphasize enough how privileged we were to be part of such a project, of such an endeavor that aims to raise awareness of rare conditions, but also help in standardizing the care delivered for this condition, and also improve the adherence to clinical practice guidelines. And I may stop here. Thank you very much.
Thank you very much, Suleiman, on this very comprehensive review, and I think that it will generate lots of discussion. However, I haven't seen any in the chat, but please feel free to put some questions. I already have some, which I really hope I will have some answers from Suleiman. I know it was a little bit difficult for Suleiman because we are mainly representing pulmonary hypertension, and he could not go into details regarding this paper. But we have another esteemed speaker, Marion Delcroix, who was one of the leader of the guidelines and also one of the key drivers of this paper. So Marion, the floor is yours, and please go into details regarding pulmonary hypertension.
Thank you. I'm taking my slides. Okay. So you see my screen?
Yes.
Strange. Okay. So my role was to speak to you about the implementation of the quality indicators in PH. And here are my disclosures. So first, I will start with the quality indicator in PH. These are the introduction and the central figures of the guidelines. And you see the first group, of course, is the one where we developed the quality indicator. As the other group have different therapeutic approach, it was not possible to put them all together. So this is the paper that Suleiman published in 2023 with the graph you have already seen. And here is on the right side the list of the indicators who have been chosen, and I will go in details. First, starting with structural indicators. So you have seen that in this approach, we have different type of indicators. And so the structural framework is first how you have, in which structure you will treat the patients. And so one of the important things is the first recommendation to have a specialized multidisciplinary team. And this corresponds perfectly with one of the first recommendation, meaning of the guideline, meaning that it is recommended that PH center provide care by multidisciplinary team. And you see the recommendation is a class 1, which means that this is really something you have to do, see based on expert opinion. And most of the things we will see in these quality indicators are related to expert opinion and not through data. And that's why validation is necessary in the future. Anyway, the second important point that you see here is that your centers had to participate to international or national registry. And this was also one of the fundamental recommendations for the PH centers. You see also that they have to collaborate with patient association. You will see that it is something which we'll see in the process later on. Now, when we have this PH center, you see that there are some criteria which we have to demonstrate then if we want to evaluate this quality indicator, that having a ward with a care provider who are expertise in PH, specialist outpatient service, 24/7 emergency care. So these are the things which are defined as indicators of the structural framework, which is okay. And you find them again in the guidelines where you see that we have here put together what is the ideal composition of a pulmonary hypertension center with core member on the left side and extended membership on the right side. And so this is, again, something which was completely identical then in the guidelines. In these hypertension centers, we also define processes which are, as you see, the quality control and the audits. Now, the second domain which was chosen was the diagnosis and the risk stratification. And so you have here on the right side the diagnostic algorithm, where you see that we have a number of examinations which are used to come to the diagnosis of pulmonary hypertension. And so each of these evaluator points corresponds to a guidelines recommendation. Again, we have to see the proportion of the patients who have had pulmonary function test, and this is one recommendation to do that in these patients. We have to see echo, and this is also something which is crucial. Again, the proportion of patients who have had the right heart catheterization, this is really top crucial, and it is recommended in the guidelines. Then we have the perfusion scan in order to identify the patients who have to move to the group 4, which is also a requirement of the guidelines, and the proportion of patients who are evaluated for connective tissue disease, which is then included in the biology test who have to be taken in the guidelines. And then we have the vasoreactivity test. So the proportion again of the patients with idiopathic hereditary and drug-induced PH who have had vasodilated testing. This is again something which is a very good measurement of quality, because if you don't do that, you miss the very small number of patients who can nearly have normalized pressure with only the use of calcium channel blockers. Then we have the evaluation of the 6-minute walk, functional class, and BNP, which are part of the stratification of the risk which has to be done. And again, this is the proportion of the patients who have this evaluation at diagnosis. And finally, we have here the quality of life assessment, which is considered an important quality indicators. However, you see from the guidelines that having a health-related quality of life was only a recommendation class 2B. And this is not related to the fact that we don't think it's useful, but just to the fact that very few of the centers currently do that. Now, the next point was the initial treatment, and you have on the right side the complete treatment algorithm. And you see that we split the patient according to the risk from low, intermediate to high risk. And that was then the base to have this recommendation that the patients with a high risk, sorry, they need to be treated with intravenous prostacyclin, which is also what is shown in the guidelines. And then for the patients who are having, sorry, a low intermediate risk without significant cardiomorbidities, they have to receive combination therapy with one PDE5 and one endothelin receptor antagonist. And that's why we have this recommendation to see the proportion again of the patients who are followed according to the guidelines. Now, what is the proportion of patients with a diagnosis vasoreactive PH who are indeed prescribed calcium antagonist comes also from a high level recommendation from the guidelines. Now, the fourth domain was the follow-up. And then you have the proportion of patients with a diagnosis of PH who had their risk assessed at follow-up by a validated tool. This again was coming and in agreement with the guidelines telling you that at follow-up, you need to determine the functional class, the 6-minute walk, and the BNP in order to evaluate the risk. Then we have the test who has to be performed during the follow-up. And we see again that we find that the 6-minute walk, the functional class, the blood, the NT-proBNP have to be performed also at follow-up in order to be sure that your patient has improved with treatment. And again, you see the health-related quality of life, which is there as a secondary measurements, because we have, most centers don't do that. Now it has largely improved over the last year, but also patients don't always are interested to fill the documents. And finally, we have also to see that the patients with high risk have to be evaluated for lung transplantation if they stay in high risk at follow-up. And this is also one of the recommendations. And finally, we have the outcome. And the outcome, the main outcome, you would say it's survival. However, the survival of patients is so importantly related to the case mix of patients that you have. If you have older patients, if you have more of one of the sorts of pulmonary hypertension, which has a more mortality, that it was difficult to use it as an outcome measure. But what was improvable was the median time between the diagnosis and starting PH therapy, and also between referral and starting this PH therapy. So it's important also that our outcome measures are improvable, are instrumentalized, so that you can really see that when you measure, you are able to improve the measurement with time. So now what is the implementation of this quality indicator in PAH, locally, nationally, or at AU level? Well, it's one of the implementation you could consider is what happens at the level of the ERN, derived from the guideline from 2050. And at that time, we had a number of patients who should be treated, and also the number of procedures who be done by the center. This is one of the ways to look at the structure of the centers, but has not been really evaluated point by point in a really prospective way. So we have this instrument, we have a knowledge of tests who should be done, but we don't measure that at the level of ERN. Well, if you look at this document, which is on the website of the ERN, you can see these criteria here, which are available for everybody, but again, not used for measuring quality. So finally, the only country where I can find really evaluation of some of these parameters is the UK, and it's not surprising that our first speaker is coming also from UK. You have national audit of pulmonary hypertension. And so what was the aim? So it's a measure the quality of care provided to people referred to PH services in UK. And so they are looking at pulmonary hypertension service, if they are appropriate, are patients receiving the right treatment in a timely manner, and what are the outcomes for patients with pulmonary hypertension. And so you see here that we have a number of factors which are evaluated. They say, for example, PH should participate in an audit. PH centers should see a sufficient number of patients. So you have here a number of factors that we will detail more here, because here we have really an interesting things that you have the follow-up, and you see that for some of these parameters, there is improvement. Patients should have a pre-treatment functional class measurements and exercise test recorded. And you see initially in 2015 was 80%, and it moved to 98%, 96, 92. Here you have, of course, the effect of COVID, and also in UK, the effect of COVID on the care for pulmonary hypertension was really measurable because they have all these factors. So many of them are quite similar to the one which has been published according to the ESC methodology. So something we miss are quality indicator in chronic thromboembolic pulmonary hypertension. And that would be really interesting, because there we have different things which can be looked at. First is a structure of your centers conform to what the guidelines say. Do you have, what is the training of the people working there, the surgeon, the BPA, interventionist? What are the volume of procedure they are doing? And also in the, not in the guidelines, but in the statement from the RS on CTEF, you see that we have benchmark for postoperative mortality, which should be less than 5%, as was set in an international CTEF registry. And we see also that in the very large centers, like the San Diego centers, the mortality was lower than 2.2. So looking at the mortality of the centers performing the surgery is really a good quality factor. And so this is something we really need to work on. In the UK, because there is only one center doing the surgery, they didn't have that as a factor, but you say that they looked at this in UK, you know, some operations are done with a large delay, and general surgery, 6 months waiting time. So it was interesting to see that the waiting time for pulmonary endarterectomy should be less than 4 months. And you see it's not the case, only 11%, 23%. And the waiting time for BPA should be less than 18 weeks. And this is available, but again, was delayed by the COVID pandemic. So there is still a long way to go, and this is something you can easily see. Of course, this was published in 2022. You see that the number of citation of the paper on the guidelines is 800, while you look that even if the publication was delayed by 6 months, there is only one citation on the quality of life paper, which means really the people are looking what they should do, but they don't get to the step of measuring what they do. So thank you for your attention.
Many thanks, Marianne, for this insightful presentation. And I'm really happy about your last slide, because probably we can move on this with the help of this webinar. And let me turn to our last speaker. I'm really happy to welcome Pisana Ferrari, who is also a co-author of this paper. Pisana is a patient advocate and representative, and we are really looking forward to seeing the patient perspective in a little bit dry subject matter, because it's always numbers and statistics and so on. But I think it's, as previous speakers enhanced, it's really important for patients also to measure actually how we are getting treated in hospitals.
Thank you, Gregory. I'm going to share my screen. Right. So thank you for the introduction. I was a patient. I suffered from pulmonary arterial hypertension for 14 years. And 21 years ago, I underwent a double lung transplant. So I was diagnosed before any treatments, expert centers, or anything was happening in the field. So it's been great to see all the progress, including this, of course. So I'm going to be talking to you about why it's important, why these quality indicators are important from a patient perspective. So my first slide. First of all, I think that including patient representatives in the development of the QIs already is very important, because it acknowledges the importance of the added value that patients can bring to discussions. Why are the slides not moving now? Okay. So the composition of the group also is interesting, because there were 30 experts with very, very diverse backgrounds. And this underscored the need for a holistic approach to PH care. Holistic evaluation is mentioned also in the text that goes with domain 1 about the structural framework. And of course, the need for a multidisciplinary team reflects this focus on a holistic approach. Another very important point in the text, it's mentioned that it's necessary to understand the continuum of PAH management and the key process of PAH care. And this emphasizes a good understanding of the patient journey. Also, the inclusion of a QOL assessment as a primary indicator in domain 2, which is about diagnosis and risk stratification, recognizes the importance of incorporating patient-reported outcome measures early in the diagnostic process. And this contributes to a more comprehensive and patient-centered approach to care. Quality of life is also a secondary indicator in domain 4, which is about follow-up. And the inclusion of a proportion of patients informed about available patient association support groups as main indicator in domain 4 really acknowledges the importance of patient associations and their role in PH care. So this is a very, very important indicator, as seen from, of course, the perspective of a patient. And of course, this aligns with the ESC-ERS guidelines recommendation for closer collaboration between PH centers and patient associations. And Marion has mentioned this as well. But there are also other reasons why this is important from a patient perspective, because comparing defined quality indicators helps identify areas for improvement. And one very important one that Marion mentioned was an earlier diagnosis, which is one of the key problems in pulmonary hypertension. Healthcare professionals can act on these findings and develop plans for enhancement. This process serves as a motivation for clinical teams, and it facilitates international comparisons, collaborations, and of course, the setting up of registries. It was very interesting to see the audit that was carried out in the UK on this topic. And the application of quality indicators has demonstrated as evidence that it has an impact on the quality of care and subsequent outcomes. In future, potentially, information about PH associations could be mentioned at the time of diagnosis. This is perhaps one small gap in domain 3. So overall, I think as a patient and patient advocate, we can only welcome this paper and this very important step forward in improving care for patients. Thank you for your kind attention.
Many thanks, Pisana, for the patient insight. I'm just checking our chat, but I haven't seen any questions so far, but I have many questions. One of them should be addressed to Suleiman because you showed us lots of graphics about many papers. So once it comes to building up such kind of structure for diseases, could you please walk us through regarding the methodology, how other disease areas should start working on the development of quality indicators? I would be really happy to learn how it is structured or whether there might be any points where really attention to be paid in hurdles and difficulties.
Yeah, thank you very much for the questions, and thanks very much for the great talks from Marion and Rizana. Really great talks. I think there are two parts of your questions. The first part is how quality indicators for other rare diseases can be developed, or even how quality indicators for other forms or other types of pH can be developed. And practically speaking, or theoretically speaking, that is straightforward. The methodology paper is published, is available on the public domain, and it's been tested and repeated and replicated successfully. So any interested stakeholders or any interested group can develop quality indicators for any other form of pH or any other rare or even common disease. The difficulty, though, however, is practically speaking, and I think Marion showed it very clearly how there is a huge interest in guidelines in terms of citations, education, dissemination. However, there is very little uptake still in the the understanding and B, the implementation of quality indicators, and that is a huge gap in care, and that is a huge gap in healthcare provision, not only for rare diseases but also for common conditions. So I think most of the quality indicators that have been developed for the purpose of improving care, of improving understanding of the guidelines, implementation of the guidelines, and implementation of prognostic or beneficial or useful therapies. However, the adaptation of these therapies remain suboptimal. So any effort, any educational activity, any quality improvement project, any webinars, anything that can raise awareness and help increase the implementation of such endeavor or such an exercise would definitely be welcome.
Many thanks, Suleiman. I also see a question for Thomas, so I'm trying to raise it again, which includes actually two questions. So the one of them is coming from Thomas's the estimation of the efforts to be made in order to make such kind of a paper, which could be also supplemented with an additional question that how you think such kind of structure can be implemented in the practice in terms of the normal reporting and data collection of the healthcare professionals, because once you are having a paper, theoretically it's very nice to have, but on the other hand, as Marion pointed out, how it can be in a real practice in the everyday life, how we can collect, report, and systematically compare our data.
Mario, please go ahead, but I think you're on mute.
Oh, okay, sorry. If I can say something, one of the big requirements is the desire for transparency, which is not very diffused in our medical community. And so I think the patients are the one who have to act, because in UK it was started like that. It's a patient association who started together with the health authorities, of course, to want to gather the information at the level of the centers, hoping they will put this data together without any stimulation. I think it's too optimistic.
Thomas, you turned on your mic. I presume that you would like to raise a question. No? Okay, so Suleiman, I think that my question was partially answered by Marion. So the first part, if you would mind, sharing your expertise how you think people and working hours should be put into um, in order to have other diseases having such kind of structure? What's your estimation, raw estimation about this?
Yes, I think once, I think I totally agree with what Marion said. I think once patient groups and patient association raise the, I'm not going to say the concern, but raise the demand of measuring or quantifying or assessing how the care delivery of any rare disease is provided, then regulators as well as healthcare providers will feel obliged to develop methods by which they can measure healthcare delivery. So I think I can totally agree with Marion that probably patient's voice is a key here. Obviously, it has to be supported by regulators. I think in the UK, what helps is the presence of NICE. I think NICE, which is the National Institute of Clinical Care and Excellence, is quite useful because NICE demand healthcare providers to measure. NICE even publish their own quality standards, which is a very similar term to quality indicators. And those quality standards, even if they are not legally binding, the healthcare providers are expected to meet those quality standards. So the presence of any regulatory body that publishes or recommend certain quality standards or quality indicators for rare diseases in particular, that would definitely raise awareness and improve care delivery for those conditions. And I think what we can as a healthcare community, in addition to what Marion suggested, that increase the transparency and the accountability, because again, it's about transparency and it's about accountability. How accountable are we as institutions and as healthcare providers to our patients? And then if we are accountable, then we should really work hard to develop those methods that can assess our practice. And then we can identify our mistakes and be learned from those mistakes so we can get better every single time. The other thing I think we should really get better at is collecting data, and we don't really tend to collect data perfectly. Even in the UK, despite the presence of national audits or national registries for a number of conditions like PH or heart failure or MI, there's still a lot of room for improvement in those registries so that they can capture bigger cohort of patients or bigger group of patients in order to understand the pattern of the disease and the pattern of the treatment for those conditions. So I think those are probably the two key parts, increasing accountability and transparency and improve in data collection.
Yeah,
Yeah, many thanks, Suleiman. I think, sorry, just somehow it resonates the question raised by Meltem in the chat. So how we can involve more patient association in such kind of work, but I think that you almost covered this. So it seems that patients and patient organization should push a little bit. However, it's not really clear for me how we can, as patient association, interact in such a way, but probably Pisana has the solution.
No, it's not a solution, but it's a suggestion, because I think maybe what we could do is a kind of a lay summary of this article on quality indicators, a paper that explains in a very simple terms why it's important for patient associations, why they should be proactive in this, and I totally agree with Marion that they should be, and how they can go about it, because this is quite a complex article. And we need to extract what's important for the patients there and why we need to act on it. And kind of make a call to action in a way. A paper, a lay summary with the key points and what we can do, who should we contact, or what we can do. And we can all promote it on social media. I mean, talk about it. Talk about it. There's been very little about the quality indicators. It's not being promoted, really, not by patient associations. We should.
Yeah, many thanks for this comment and excellent idea. I think partially it was covered by Marion, but I'm not sure whether Suleiman or Marion should be addressed with this question. As you know, we have 5 main groups within PAH, and mainly we are focusing on the first and the fourth group, so PAH and CTEP. Do you think that is there any difference where we do not have, for instance, other rare diseases, so structured kind of treatment strategies, pathways to build a quality indicator? So is it much difficult or more difficult to build up such structures, for instance, for other group of or cohorts of patients, for instance, second or third group or fifth, or for instance, other rare respiratory diseases where they do not have such kind of structure what we have in PH?
Marion, I'm sure Marion would definitely be better.
No, I think the advantage we have in PH is that we have very good guidelines. And that's the first step. You need to have practice guidelines in order afterwards to measure what if they are implemented as Suleiman showed. And so there are many diseases where many rare diseases without guidelines, and there are some who are perhaps, if you don't have treatment and so, then it's perhaps also more difficult to look how many patients, percent proportion of patients who are on treatment. So I can imaging. Plus, we have to say that we had that incredible support by the ESC, which is financial methodologist. You cannot do that for nothing. You really need resources. And so it was good that the ESC provided the resources. But if you don't have somebody putting, I cannot imagine the cost of this, because it's a bibliotary library, and it's methodologists, it's all the experts who need to be put together. And so it has a budget to do something like that at that level of methodology.
Yes, so we need to follow the step by step. So a structured way of pathways and recommendations, or probably ERS statements, might be also enough ground for building quality indicators. So if we have a common understanding based on the literature research, what is the common approach of in terms of diagnosis or treatments of other rare lung diseases, that might be a good starting point on building quality indicators. I saw an interesting point in the chat from Thomas. I do not know whether any of the speakers would like to pick up that question and answer. It is about how we can save money, but at the same time not deteriorating the care of patients. I think that was the main message, if I'm right.
Is the question for any particular person? I think we know when we improve our adherence to guidelines, it's about the population-based money, isn't it? It's not about saving money. It's about improving quality of life and improving treatment of any condition. And whatever the cost of that treatment, it will reduce morbidity, to reduce mortality, and then that by itself will be financially cost effective. And that's what even NICE look at. So NICE, whenever they appraise a treatment, they normally look at the cost effectiveness of that treatment, and that cost effectiveness is quite complicated analysis, but what they tend to do is try to estimate what is the benefit gained from implementing a therapy or recommending a treatment option, and then how can that will improve the quality of life or survival on a society or a population based level, and that will then determine whether a certain therapy or intervention is cost effective or not. So I hope that answered the question, Marion.
I have a question for Suleiman. Do you know the willingness of the ESC to go into collaboration with other societies to have, for example, the new quality indicators for CTEP, for example, because we think this is a disease where we need surgeon, we need cardiologist, we need pneumologist, we need and so that would be for me the following step is to do that for CTEF with, for example, the ESC, the ERS, and then the Society of ESHLT, and so to put them together in order to move forward. Do you have an idea how positive is ESC for doing this sort of initiative?
Yeah, I mean, I know that the quality indicator. Obviously, I can't speak on behalf of the ESC. So, I mean, it's mainly it's just about. I know that the ESC are very keen to develop any strategy, any document, or any recommendation that can improve adherence to prognostic and life-saving therapies or treatment options. But it goes exactly to the points you've raised earlier. It's about the manpower, the availability, because most of the ESC activities are based on volunteers, and all people who have worked on this document, for example, volunteered their time and expertise to develop this document, which took time and effort. And the ESC provided that sort of administrative support, arranging the meeting, arranging the discussions. But it is so there is definitely willingness from the ESC to do any effort and to support and endorse any effort that can improve adherence to guidelines and adherence to prognostic therapies. However, any sort of proposal or any suggestion has to be supported by a strategy of how these documents or paper can be developed. But if there is enough manpower, volunteers, expertise who can provide the input required to develop any high quality recommendations or high quality indicators, I'm sure there will be acceptance to do that.
Actually, we heard how patient association can push such kind of initiatives in other disease areas, but I was wondering whether you can identify some selling points of building quality indicators for healthcare professionals, and for physicians and academics. So how do you think it can be easily said? Because we know that many reporting systems are already available, and hospitals need to report lots of pieces of data to various directions. But putting another burden on the shoulders of these reporting teams might, ring the bell that, okay, that's great. You have this structure. You are requesting more and more data from our end, but can you please let us know that why it is good for us? So do you have any, recommendations or ideas how we can come up with this idea in other disease areas and say, and look, that's a good thing. You should do it.
Well, if I can speak about the implementation of this sort of things, we have in the hospitals initiative to quality measurements. And when I come with a list of these 25 parameters, they just say, pick one, and then we will try to follow up. So it's indeed very difficult because we have a lot of information in text forms, but very few of the information is on data form. And that's a problem, that we need to extract manually all these data from the files in order to report them. And so there is a work everywhere to have more digitalization of the data, but it's insane already a very big burden for the centers. But we move slowly in this direction.
It's good to hear. I just realized that there's a unanswered question in the chat, and I'm just wondering whether Thomas, you would like to pick this up because it's about ER-LUNG role. It was raised by our patient advocate friend Hansi from Austria, and he's wondering about the role of. Oh, you have already answered, Thomas, in the chat. I just realized in
Yes, I
this
tried to.
very minute.
Okay. Yeah, I think
Yes.
that's very close to what Marion said, that there's a lot of work connected to documenting the indicators for each and every patient. And if you want to do this for a big organization, you have to find resources. Who's going to pay the work that has to be done? And if you have a system like in the UK where your work is being paid and the documentation of quality indicators belongs to the work that is requested from you and can be requested, then there's a clear way of how to implement this. But in most systems, that is not available, and that puts up the question, who's going to pay for all the extra work in documenting these indicators? And this is my answer to ERN-LUNG. Yes, we can certainly try to facilitate this, but if we go and ask all of our members, you have to document all the quality indicators for all the diseases that are in the spectrum of ERN-LUNG, they will say, okay, who's paying for it? Because most of the healthcare providers organized in ERN-LUNG don't have a structure where they can rely that their financial system will allow them to be paid for the extra work. It's a little bit stupid that this is considered extra work and not part of our work as a doctor or as a team. But this is the situation we have right now in Germany, that we do not know who's going to pay for this.
There are some quality programs. For example, we have surgery for the esophageal surgery, which is a rare cancer, where you have then a limitation of the number of centers in order to have more concentration of the number of operations. And these centers who get this recognition to do that, they have to report numbers, survival, things like that. So when you go for concentration of care, then most of the time you need to report to show that this concentration of care improves the quality of the care. But that need to be that's programmation of health, and it's not everywhere available.
Yes, Pisana, I just saw that we are running out of time, and I see a very interesting comment from Wendy, and I was wondering, Pisana, whether you can comment on this. It's about transparency on treatment. And do you think that there might be moves from the patients and choosing the highly rated healthcare professionals based on such kind of quality indicators? What's your thoughts about it? Because we know that we are always advocating for centers of excellence where we would like to be treated, where we know that there's a big volume of patients, which we believe that generate the biggest knowledge. So what's your thoughts about these numbers where a patient might have access and might be aware of such kind of quality indicators? Do you think that kind of patient movement could be generated based on these numbers?
Well, at the moment, there are no ratings, and it depends very much on the different countries. For example, in France, there is a defined reference center and the centers that report to it. In Italy, there is no defined center of excellence. So it depends very much on the local situations. It's very difficult to have ratings. But of course, I realize from what I've heard from the others that it's financially very difficult to implement quality indicators, but there's certainly no harm in raising awareness about them among the patient associations. And I've read a few very positive comments about my idea of doing a lay summary in the chat. And I still think that would be a useful move, that patients become more proactive in promoting them. And one day we may actually have ratings and be able to choose the best centers based on the ratings, hopefully.
Many thanks for these very positive words. I think that we managed to answer all of the questions raised. If there's no other comments, I would like to conclude this webinar with good feelings that we might see new quality indicators coming from other areas, because I think that this is the future in terms of raising awareness of rare diseases and also contributing to the quality of life of patients through these expert centers. So I would like to thank again our esteemed speaker to be here, and also those who are joined us and devoted their valuable Friday evening to this webinar. Many thanks again, and take care. Have a nice evening. Bye-bye.
Thank you. Bye-bye.